Good evening. My name is Matt Calendrillo. I am the current vice chair of the NCCE, and we're excited to bring this webinar to you this evening. I hope some of you have stumbled into our webinar series for 2022 already, where we've hosted a number of different resource sharing webinars, sometimes pre-recorded and oftentimes during that lunchtime hour. The idea has been kind of a low stakes environment to bring kind of current resources that people are using in their clinical education programs, whether it be on the academic side or the clinical side in real time. And perhaps you can modify your own program or brainstorm some ways to improve and strive towards excellence and best practice within clinical education. So this evening is going to be a little bit different of a feel. We've collected a little panel for a discussion about kind of their journey within clinical education. There's just 4 all-star individuals that we'll hear from. We'll be doing introductions with them shortly. 3 are in the clinical education professional side, whether it be academic or clinical. And we also have an all-star student that's going to be starting his terminal experiences in the next month or so. So I hope that conversation can lead us towards a better understanding of what it means to be in the clinical education community, the different hats that people can wear within it. It's not just simply DCEs and SCCs or CIs, but there's different touch points along that continuum that people play. And then the story that I think is often untold or missing, especially for students and new graduates, is what does it take to enter clinical education, right? How do you become a clinical educator? Is it simply just being an expert in specialty practice? We know that's not the case, right? So what are some of the touch points along people's careers that have nudged them towards this as a portion of their professional day? And then how did they do that? What was the preparation? How did they get to that standpoint? So I really hope that story can showcase some excellence in clinical education. I truly believe that clinical education is awesome. I think it is sexy. I think it's a story that's untold. And I'm hoping that this evening we can shed some light onto it. So that being said, a little bit of housekeeping. If you're interested or you have kind of a burning topic on your mind, or you have some work or resource that you have that you'd like to share with the clinical education community, feel free to reach out to us at the NCC. We're gathering possible presenters for next season and next year. So please do kind of reach out. The best way to do it is via email, which is just simply ncc@acapt.org. I'll also shed some light on the past resources that we have within the clinical education thread. So if you jump onto acapt.org/NCCE, that brings you to our standing page that has links to a bunch of different resources, whether it be task force summaries, if it's prior webinar recordings. There's just a lot of content that seems to be growing into this hopeful kind of one-stop shop. As well, if you haven't visited ACAPT's YouTube webpage, that has information from all the different consortiums underneath ACAPT and just some wonderful resources for content itself. So again, I appreciate everyone's viewing. If you have questions, feel free to reach out to us, and I hope you enjoy this evening. Thank you so much. All right, welcome back, everyone. So I'm going to have our panel kind of self-introduce themselves and talk about their journey through clinical education. And to start that conversation off is going to be Moyo. And take it away.
All right. Thank you, Matt. Thank you so much for this invitation. I love conversations about clinical education. My name is Moyo Tillery. I'm the Director of Clinical Education at Elon University. It's in Elon, North Carolina. I received my DPT from Duke in 2011. And my interest in clinical education really started then. Obviously, I was in PT school. I had 2 excellent long-term clinical experiences in 2 very different settings. And that's kind of where it all started. The first experience was in outpatient orthopedics, very heavy in manual therapy. I had a clinical instructor who was heavily involved with manual therapy. I learned so much about it, fell in love with it. And it really changed the trajectory of my career because I became fellowship trained in manual therapy. So I think that's one thing that really speaks to the power of clinical education. And the other internship was the exact opposite in inpatient rehab. And it was very intense. It was at UNC Chapel Hill's inpatient rehab unit. And to have 2 excellent clinical instructors in 2 very diverse settings with two very different approaches to teaching. It just sparked an interest in me, and I immediately knew that I had to become a clinical instructor as soon as I graduated, but of course with some experience. So that's kind of how I got into clinical education. I became a clinical instructor. I took the credentialing courses level 1 and level 2 through APTA. I didn't have the experience in clinical practice. I was a second year early professional when I took the courses. So I found it really helpful, and it built my confidence to take students to the point where I had several students in collaborative models where I had 2 and 3 students at a time. So I've really had a nice experience in ClinEd and have recently taken on the role of Director of Clinical Education. So that's kind of how I'm here talking about clinical education.
Wonderful. Thank you, Moyo. And I think if we're kind of working through a continuum, so we've got Moyo on the academic side as a new DCE. I'm going to pass the conversation to Maggie as a residency director.
Thanks, Matt. So my name is Maggie Dangerfield. I am the neurologic residency director at Live Every Day, which is a practice in Connecticut and Massachusetts. And I also adjunct at Springfield College. So I graduated from Springfield College, kind of always interested in teaching. I actually was trying to figure out like where to start talking. And I was like, to be honest, I actually ended up during PT school. I took a year off because I was like, I don't know if I want to be a PT. I think I want to do some sort of teaching. And I always just like really I love learning. And I was like, well, you can't just learn for the rest of your life. You actually have to get a job at some point. So I thought that teaching was like going to be the way that I wanted to go. And life happened and I ended up back at PT school, and I'm super thankful for that. But I always like day one walking into DPT school, I feel like I always was really interested in like how we can learn. And I thought that the way I was going to do that was just like teaching patients. One of our first semester classes was like teaching and learning in physical therapy. And I was like, this is great. Even though I don't really want to teach, I can teach patients, I can be a physical therapist. So all through school, I always was like kind of interested. And then when we were going on clinicals, I was starting to just see that like there were more roles in teaching and education in physical therapy that weren't just being a teacher in front of a classroom, and like clinical education was that. So after school, I moved to North Carolina and I started working in an inpatient rehab unit, knowing that I wanted to do a residency myself, more so because I figured if I was going to be trying to teach at some point in some way, I wanted to like make sure I was an expert in that content area. So in terms of like why I was seeking out residency, it was more just like I wanted to specialize in neurologic physical therapy. That's where I love PT, and that was how I wanted to do that. So while I was in my residency, I made some connections in the area and started doing some adjunct work at a local PTA program through just like neuro lab and neuro coursework. And then eventually an opportunity opened up and I taught full time at that PTA program. So I had classroom experience there. And then I was actually at a conference to learn more about like teaching and opportunities. And I ran back into Matt and ended up talking about just like ClinEd in general, but then like residency and what that was. And having gone through a residency myself, I just understood like what that really was and had an opportunity and ended up coming back up to the Northeast and at Live Every Day and developed the neurologic residency program for Live Every Day. And so that was really cool, just getting to, or is really cool. I feel like it's always a work in progress, getting to see like the curricular side, but also that like mentorship piece of things and like what residency really entails. So I think in terms of like clinical education, my view on it is definitely like that like residency view in terms of like expert level care, but being involved in Springfield College and that like neuro thread, I get to see the student learning. So I get to see that really cool transition of like, there's classroom learning that happens, there's clinical education learning that happens, and people get out into the field, and then there's like expert level training that happens. And so I think that's kind of like why I'm here.
I love it. Thank you, Maggie. I think the little highlight there was just that aha moment of many touch points or many roles within educating as a physical therapist. So you mentioned like we get into it for educating the patient themselves, and then you identified I think like half a dozen other touch points along the way. I think this is going to be great for the discussion. Thank you. Kayla, to you.
Sure. My name is Kayla Gomes. My pronouns are she, her. I graduated from Northeastern in 2018. Yes, 2018. And since then, I've practiced predominantly in hospital-based outpatient. I've had a few stints of inpatient rehab before and after the pandemic. I remember telling Matt during the pandemic, like all my hobbies, which involve being indoors, like with people and yelling at them or singing at them or whatever, were canceled. So the first year and a half of the pandemic, I really focused on some work projects that I was wanting to do. And so I got my NCS. I wrote and published a paper with a research group at my first job. I took students for the first time. It's something I was always interested in. I think in a year and a half, I took 2 full-time students, 1 part-time student, 2 of which are now working at the site where we had our relationship, which was great for them. I'm excited that they were able to transition from student to employee because they had such a great experience. And when thinking about like, when did I get into education? I like reflect back on when I was like a kid, because my mom works in education and she specifically trains other educators on how to improve outcomes in those in like the special ed field. So from a very early age, I saw my mom just kind of being a boss and like reading books and reading data, but being able to synthesize that and teach it to the masses, not from a PowerPoint, but in breakout groups and all these cool programs and materials. And I was 7 years old helping her make materials. And I just thought that was the coolest thing ever when I was little, just because, you know, your mom is cool. But like, I still wasn't like into education until I was in PT school, and you're doing like that group studying and everything's really, really stressful. And I realized that I learned more when I was teaching my fellow classmates the material, which, as we know, helps with retainment. And I started to notice my fellow classmates like that aha moment. And I was like, that's really cool. I like that aha moment. And I'm like, what? Like, how could I make this better? And I decided to, on my, you know, last year of PT school, when I was on my last clinical rotation, volunteer, but like kind of beg my neuro professor at the time to let me be the tutor for the year below me. And then at that point, I had a little bit more clinical experience under my belt. I was able to, I thought, better teach the material to the students who were coming in for tutoring. And I was just, you know, the bug was bit. Like, I was just like totally into it at that point. And I too took the credentialing course offered by the ABTA. I've only taken level 1. I'd love to take level 2 at some point. And I just took my 2 full-time students as soon as I could. I think I was practicing for a year and a half or 2 years. Things kind of get blurry with the pandemic when I had my first student. And then pretty quickly after, I've taken another student and then a third. And I'm just into it. Like, I was reading a lot about it when I first became a CI and just trying to integrate it. When I was a student, I remember like having CIs who were super into clinical education, were really effective educators. And then I had some CIs who weren't really into it and were not the most effective educators. So you take things from both of those experiences and you apply it to how you're going to be a CI. Which is another reason I did that for my Centennial Scholar Project, a project on burnout for all the stakeholders in ClinEd, because I was seeing what was going on with, you know, CIs and students all across the country with what was going on in COVID-19. And that's how I met Matt and Mo, and it's just been a great experience.
Thank you, Caleb. There's a million questions I want to ask in there. I'm going to wait for Duncan.
I know, I felt like I was going all over the place.
Your excitement is like palpable. I absolutely love it. So Duncan, an intro from you, if you don't mind.
So my name is Duncan Satterlee. I am a student at Springfield College. I just finished my 5th year, being my 2nd year in the PT program. So starting in August, I'll be in my 3rd year, my clinical rotations. My first one being in Connecticut at Live Every Day. Second one being out in Cincinnati. So a little bit about myself. I have a big interest in sports, played baseball at Springfield College for a few years. And I think that's kind of where my interest for PT really started. the science behind sports always was really interesting to me, kind of breaking down, the mechanisms of a certain movement in sports. So being a baseball player, the mechanisms of pitching, the torque involved in throwing a pitch, and all these different things. And then kind of transitioning to some injuries that I had and kind of figuring out, why am I hurt, or why is this person hurt, and what can we do to help them, kind of sparked my interest for PT, kind of that sports aspect with helping people, bringing it all full circle. So that's really where I started being interested in PT. Kind of unique with Springfield College is it is one of those 3-in-3 programs. So coming out of high school, I kind of had to know that I wanted to do PT, and luckily I still am kind of interested in it. At this point, would have been bad if, you get to year 5 and I tell my parents I'm not really interested in it anymore. But no, I'm still really happy to be in the program and have learned a lot so far, finishing up through all of my didactic coursework. I'm just really excited to get going with my clinicals. And I think throughout my time at Springfield College, I've kind of started to grow my interests of what aspect of PT I want to do. And mentioning sports, it is kind of stereotypical, but at this point, I'm very interested in that ortho sports related PT, with some interest to maybe get started in my strength and conditioning, and maybe further down the road, go to a residency program with orthopedics. However, I actually have started to grow a pretty big interest in neuro. That being said, you can't really have ortho without neuro, or neuro without ortho. So that interest is a good thing, because there's always going to be both systems working together. I think now I just have to kind of figure out what path I want to go down before I, sign off on a residency or sit down for a board certification. So I think that that's something I'll come to figure out on my clinicals, and I'm just super excited to get going with those and really happy to be here. So thank you for having me.
Yeah, thank you as well, Duncan. And I think your perspective is going to shed so much light on those that are kind of tuning into the panel. So appreciate having you. Where I want to start, and we mentioned this kind of before the call, I want to start with you in terms of when you had a sense that clinical education, right, was part of becoming a physical therapist, and was part of physical therapy education. Was there a moment in time where you were sitting in class and they said this, or this? Was it prior to school? What's the story behind where you felt like you were introduced to clinical education?
Yes, so coming into Springfield before my freshman year, I knew I was applying, and there was kind of that talk that 6th year is going to be doing a clinical or doing clinicals. But at that point, I really had no clue what that meant. I just kind of thought, oh, I'm going to be doing an internship per se or whatever. But I think I didn't really kind of get a grasp on that until probably my junior year. So during my junior year, we had this experience at Hartford Hospital to do a mobility program with some of the patients that were there, just going in and helping them get up, walk, and moving, because we know, movement is medicine. And that was a big thing they talked about at Hartford Hospital. A lot of patients, I was actually on the cancer unit when we were there. So getting patients who were rather sick and trying to get them up and moving, we know how good that is for them. So that was kind of that first glimpse at not really a clinical, but actually doing something PT related per se. And moving forward from there is when I started to really get a grasp of what that clinical education was going to be. Then moving into grad school, especially that first summer, kind of harping on everything we're doing with our classes, with our lectures, and everything that at the time might seem mundane or annoying, especially being the COVID year. My entire summer courses were online. So I'm sitting here, why am I on my computer for 6 hours a day? But as time goes on, really introducing, you're doing this for your clinicals to get you ready to practice. And then once getting back to school, we had those ICE experiences, which is the integrated clinical experience, and started to slowly kind of see that clinical piece to our learning. That's not the didactic work, but actually getting to practice what you're learning on a real patient, working with different practitioners in different settings, and kind of have it come full circle, and then just have it grow throughout the years of my grad school, and be able to be more hands-on, more involved as that comes, and then being super ready at this point to take on clinicals in about a month. So that's kind of how the clinical process unfolded for me.
I love it, Duncan. So I love the super ready. kind of statement there, right? And I think the clinical education program has done you right? So they've slowly introduced you to it, given you part-time experiences, built up your confidence. You're obviously a reflective learner. You've grown through the process. Do you mind shed like a tiny bit of light on where you feel like that confidence has grown through the clinical environment?
Yeah, I think it just, the more experience you get, the more you kind of say, okay, I can do this. I am in the right place. And I've always tried to be confident, or even if I'm not, like show that I'm confident, maybe give a false sense of confidence. But in reality, I think it comes with just kind of a passion for what PT is. And with that, like, you just build confidence through wanting to do it. And I know that it's grown over time. My want to be a PT has increased. And I think that's where I just feel like I'm in the right spot. So with that, just every time I'm in a clinic, not in a class, just trying to apply whatever I'm learning and really, really focusing on whatever it is in front of me has just done a lot to, one, build my confidence, but underneath that, build my education a ton, because you learn so much in a class, but once you actually get those experiences hands-on, you know, getting to talk to a patient is a ton different than talking to your lab partner. Working with someone with an actual injury who's in pain is a lot different than, again, a person in my class who has pretty much nothing wrong with them. So the more you get exposed to that, and the more you kind of can practice that, bounce ideas off of a clinical instructor, talk to a patient and get to put those tools to the test, it just grows your confidence. And even if something goes wrong, I think there's learning pieces in that too that just continue to move you forward. So.
Wonderful, Duncan. I think you have a lot of clinical educators smiling right now. That's wonderful. That's a great reflection on it. Kayla, to you and the many questions I have from your simple intro, right? So we've got a woman who is relatively new, right? So you said 2018 graduation. Oh yeah, there was a pandemic. Oh yeah, and then you list this laundry list of, oh, by the way, I was the Centennial Scholar for the state that I reside in. I mean, that's a huge deal within itself. Research, I'm hearing your NCS, I'm hearing now you've taken multiple students, 3, 4, somewhere in that
range. Three students in like a little less than 2 years. Yeah.
That's a whole lot, right? You've jam-packed your resume in such a short period of time, and I can only imagine what, you know, the decades ahead have in store for you. So I guess why clinical education? Talk about that. I know the story of the, you know, your mother and that education kind of flowing through your blood, but all of those hats that you're currently wearing, I guess why clinical education? And then when do you feel like you're wearing it, not wearing it? Maybe expand upon that.
So I think the journey to like first start being a CI came from my own experience being a student. I see it in Duncan, I see it in my students that I've had. I just feel like they're so much more confident than I was. I don't know why, because I was a really strong student and I loved talking to people. And I just remember being really scared for clinical. And luckily I had a first CI who was really, she was literally a grandmother, and she had taught like 80% of the PTs in Boston, like, because she worked at Northeastern and BU and loved being a CI. I think she took like 6 students a year. So that was a really great first experience for me. Mm-hmm. And then having CIs that were just as or more effective, or CIs that weren't as effective, some because they were going through some personal things in their life. And I ended up having to switch being a CI or switch CIs when I was a student rather. Which is totally fine. And then another CI who just really had no interest in being a CI. She told me point blank it was for her clinical ladder. And I spent a lot of time in that clinical, maybe not so much practicing clinical skills, but learning how to deal with interprofessional conversation. Which was really hard as a student, because you have that, you feel like as a student, you have that hierarchy, right? So I had a lot of talk with my school and the director of ClinEd and the CCCE at that site. And I just remember thinking, there's gotta be a better way. And like one day when I'm a PT, I wanna make sure that students have a very good, enriching experience. So what can I do to not only be a nice person and enthusiastic, but how can I be the most effective educator? So I spent some time learning the skill set required, I think, to be an effective educator. And I know we'll talk about this later with clinical education. Is it a specialty? There's like education takes skill. It's a skill like anything else, like manual skills, like anything you would learn at a residency. It takes skill to be a strong educator. I think anyone could do it if they want to be a clinical instructor. But it takes practice and it takes learning in order to have other people practice and learn under you.
I love it. Just to butt in for a second, we're in the clinical education community often questioning like how many, the term that gets used often is capacity. How much capacity can clinical education take on? So I'm sorry to hear you had poor experiences, but obviously you use them in the positive light to kind of grow from, right?
Yeah.
But the question about when your clinical education hat is on or off. So if you're defining yourself as a clinical instructor, right, and you currently don't have a student, are you part of that clinical education community? Do you feel like you've taken your hat, put on the sideline, you're waiting to be called back in off the bench? How does Kayla balance that, having this incredible skill set that you've honed, but potentially not having a student standing next to you? What does that feel like?
Well, to answer your capacity question, I like having a student a specific time of year because I recognize like, oh, during this time, I like to go hiking, or during this time, I like to travel. There's less of traveling now because of COVID, but I don't think it's necessarily fair as a CI to take, a lot of time off. That's my personal thing. And I see having a student as like my project, you know what I mean? So I want to make sure that I have the capacity to do that and I'm not pulling myself in all these different directions. But that said, when I don't have a student in front of me that I'm going to have to do the CPI for, I always like to help. Like if someone else has a student, I'm always going to help if they're off for the day. I think with my last job, there was a lot of newer grads there. I liked being a mentor for them too, if that's something that they were interested in. So I don't think I ever fully turn it off, no. Or even just giving advice to people who are CIs also. If they have a student who's struggling, or if they have a student who's really exemplary, Kayla, what can I do with them? Which is something that the credentialing course goes into as well. But no, I don't think I ever specifically take my hat off. I think maybe I just like shift it a little bit and then put it on straight. Put it on straight when my students are actually in front of me.
And I didn't know where you were going to go with the answer, but I'm glad you did, because that's what I would say as well. Because clinical education, yes, it's a touch point when you have Duncan as a full-time student. That's easy, right? That's easy to identify this block before clinical education is happening. But you're identifying people within your clinical environment, coworkers that can be just that clinical discussion, that discussion to improve patient care. I think all can get captured into using the same skill sets for ClinEd on and with different individuals. Yeah. So.
Go ahead.
No, go ahead. Please.
And like, I personally don't think that the relationship between you and your students has to end. This is my personal experience with that clinical. Like all three of my students graduated this year. It's not just a question about references. They're talking to me about job interviewing skills, negotiation, that sort of thing. Because a student comes to you with all the book smarts in the world, but you have like that real world experience. So I don't think that should just end with clinical care. I think it should also permeate into life skills in acquiring a job and et cetera. 100%,
Kayla. I love it. That's like that ripples when you throw a stone into the water. I mean, you're touching those individuals potentially for their entire career. Moyo, I'm salivating asking you some of these questions, right? So maybe piggyback off of just that conversation Kayla just spoke of, and then now your transition from truly that clinical world now to the academic world. Where do you feel like you're impactful to that student on the ClinEd side? Where are you touching them? Maybe expand there for us.
Sure. Yeah. No, I love your hat analogy, Kayla, because I've worn many different ones. Some get bigger, some change colors. It just varies. But I completely agree. So clinical education is something that never really ends. It's like you go to work, you're a PT, you come home, you're not working, but you still have this identity. And I sort of look at it as a split identity with my being a PT. So it's a sense of social responsibility that I take really seriously. To your point, Kayla, it's sort of the gift that keeps on giving. And so I'm really committed to a really unique, individualized experience for each student. That takes a lot of work because, Matt, as you know, I wore many hats when I was in the clinic as a PT outside of clinical being the CI. And so it can be a little bit tasking, but your heart commitment to what you're doing, I think, sort of carries you through. That's definitely been my experience. I've enjoyed learning about each student, their unique ways of learning. I've had to change my teaching style to ensure that my students really understand the fundamentals of this setting and this practice. So it's tricky. You don't want to compromise the fundamentals, but you also need to be flexible. That's where the hat sometimes can tilt. But I kind of look at it like an analogy to patient care, where Maggie alluded to just teaching patients, but you can also teach students, you can teach your peers. I look at having students like I have a patient. So a one size fits all exercise is not appropriate. I have to tailor it to every student, no matter what. So that's always been my approach. And I hope to think that's been impactful for my students. The post-clinical relationship is important. We're all still buddies. Some of us are colleagues now. And I get so excited and almost emotional thinking about attending graduation for my last two students before I transitioned to academia. So they actually invited me to their graduation up in New York, and I made it, and it was wonderful. And we've had conversations since about letters of recommendations, of course, but we've gone back and forth, decisions about residency. And, because I know the students so well and their learning styles, it really puts you as a clinical instructor in a unique position to guide your student, even as during the post-clinical experience and as an early professional. So that's not something that I think should be taken very lightly.
Love it. And Moyo, so now you said 5 months or so under your belt now, solely on the DCE side, that impact or that touch must feel different, right? What feels different about it? Where do you feel like, you can be candid, what feels like struggles, what feels like the skill sets, like new skill sets have to be learned?
Yeah. Well, again, Kayla, you pulled the words out of me before I got to say them, because you mentioned that teaching takes skill. And when you remove yourself from one teaching environment and put yourself in a different teaching environment, it can be quite a challenge. And so the impact that I have as a DCE, I think, has yet to be determined. But I will tell you that the teaching environment is different. We do have clinical education seminars that are more kind of traditional lecture. And listening to Duncan, and he sort of confirms the fact that I'm looking into occasionally blank faces because there's no context for what the heck I'm talking about when it comes to clinical education. So we talk about some of the basics, compliance document, those types of things. But some of the meat and potatoes of clinical education, I think, is really going to start to come after the first year and after the first clinical, where the students have had an experience to really dive into clinical education. So I think the impact is yet to be determined. We fortunately at Elon, we have tons of resources for developing your teaching and being impactful and knowing how to ask the right questions. And, having been where I was for so long with a ton of experience as a clinical faculty member, switching gears for me is going to take a little bit of skill refining. I'm just learning. So yeah, it's an interesting place to be in. Definitely quite a transition.
Yeah, wonderful, wonderful. And Maggie, to pull you into the conversation, in my mind, members of the clinical education community, I'll be broad, get siloed. We talk about this often, right? And there are people that write research on ice. And then you would ask them about a question about residency, and it's as if you're talking like astrophysics, like it's that vastly different. And in my mind, it's always like the ICE student ultimately becomes a professional, ultimately becomes a resident. So we should know, and we did an entire series on this, like we should understand that continuum. So regardless of where you're wearing your hat, we'll keep on using that analogy, whether it be at the perceived finish line at residency or fellowship, or at the starting line of, say, part-time or ICE experiences, we should still know what's going to occur up and down that same stream. So talk about how you feel residency is part of Clin Ed, and I don't know where your blinders are, and I don't know, your realm as residency director.
Yeah. So residency, I feel like, is definitely part of clinical education. When you think of like what is clinical education, you think of that like experiential learning, and like at least that's what I think of. There's a lot more to it, but like, clinical education is that like applied learning, and it's like tailored to a specific student. Moyo like alluded to the fact that, when you think of classroom learning, there's this like large group of students, and the skill set that's required is like, how am I gonna transfer this information to student A, student B, student C? They all learn really differently. How can I include all these different learning styles in my presentations and things like that? And when I think about clinical education a little bit, I think of like even if it is a 2-to-1 model or something like it, there's a little bit more of that personalized experience that she was talking about there. And so I think that like when you think about what a residency program is, it's similar in the fact that, there's a mentor who's responsible for the mentee, the residents learning, and in the classroom. And you're thinking about like clinical education, you're taking a lot of that like coursework, whether it's didactic or clinical learning that happened like in school, and you're applying it to patients. Residency is specialization, and that's like what differs there. It's a neuro residency, it's an ortho residency, it's a sports residency, it's a peds residency. But the reality is you're still taking a lot of these like broad concepts that you're learning. You're taking this like didactic information, these concepts, and you have to figure out how to apply it. I think the level of learning is different, right? You're going for expert level care, but it's still, the model is like exactly what we do in school. It's exactly what we do in clinical education. I don't think it's different than, I think it is clinical education. It's just clinical education continued on. So I don't see it as like, I don't even see it as like a separate side. I just see it as like a continuation. I don't think it's a separate thing. So
I guess the answer is probably no, but do you think it differs from a full-time clinical experience, or how does it differ? How do you stretch it? Because it's not a 10 or 12 week experience just stretched out across 12 months, right? We know that. So how have you developed your program to handle that expectation for growth and the eye on what this elusive kind of expert is?
Yeah, I think just like it's not just the expectation on the learner is a little bit, you're going to be an expert level. So the autonomy there is a little bit different, I think, in terms of like, you are a licensed practitioner, you have a caseload when you're in residency, and then you also are the resident. And to use the hat analogy, the resident hat doesn't come off ever. And so whether you're in, different programs are set up differently, but every program has the reality of, there are like mentored care times, there are didactic work, there are labs, there are times where you feel like the residency hat is like front and center, and that is like who you're being. But then there's also all this clinical time where you're with a patient. And so I think that the expectation on the learner is a little bit like in student clinical education, in those full-time clinical experiences, your CI is with you majority of the time, right? You're not very often on your own, if ever on your own. In residency training, there's a lot more time, like independent learning time, but the reality is you're still supposed to be wearing that resident hat and applying all of the learning that you're doing in residency and mentored care time. The things that you're preparing for a mentored care hour where you're treating a patient in front of your mentor should be the same things that you're preparing when your mentor is not going to be in front of you. So the reality of the learning, I think, is all similar. I just think like the responsibility, I think, is a little bit different. So we could like, overall, no, I don't think it's different. But like, if we're parsing out what the differences are, I think the difference is a little bit, and that's not to say students aren't responsible for their own learning, but I think there's a little bit more independence and autonomy in a residency program. So that differs a little bit. And then I think like just again, to reiterate, like a residency is a specialization. So I think the reality is like, it's a little bit more tailored in, but Duncan said it in the beginning, right? You don't have ortho without neuro, you don't have neuro without ortho. So the reality, I mean, there's modules in our residency program where we're lucky enough to be like at a facility that has ortho residency, has neuro residency, and like the neuro resident is going to collaborate with the ortho residents and do things like it. So as much as, yes, it's a specialty, even then there's tangents to go off on.
Yeah, absolutely. And Duncan, a little off script, but you had mentioned an interest in potentially residency training or fellowship training kind of after you start your career. What's the attractive draw at this point in your career? And maybe even from this conversation that you're hearing tonight, what do you think about taking that step?
So the first kind of attractive draw is kind of a funny one. I'm a huge Ohio State fan. And the first thing I saw when I started my freshman year was that Ohio State had an ortho residency. I didn't know what residency meant. I didn't know what it was, but I'm like, I'm at Springfield now. This is my one chance to be a Buckeye and go to the Ohio State. But further than that, I'm still like very interested in it. And I think it's because I am kind of bought into that, like be a lifelong learner, right? So at this point, I've done all my didactic work and now I get to have that experiential learning. And I think I want to just keep doing that and kind of chisel myself as quickly as I can to get into that population that I want to work with and be as good as I can. So I think that's where that idea of that drive for a potential ortho residency is really attractive to me, because it's not to say that, you know, a general outpatient is not a good place to be, but if I can get in and really get my craft to a high level as soon as possible and kind of get to that population that I really want to work with and know as much as possible, I think that puts me in a really good spot, not only for success personally, but for success of patients and, you know, in that population that I want to be treating. So that was kind of what drew me to the idea.
That immersion piece doing it. And I love the Ohio State connection as well.
Matt, can I share something that a student said to me that I feel like connects all of this continuum that you were talking about? Mm-hmm. So I had a student who, for the record, was incredibly ready for clinic. It was their first clinical rotation, but we were just talking about the didactic portion of our education versus the clinic portion. And this person said, somewhat frustrated, I wish the books, like the didactic part, could be more real life, can prepare us more for clinical. And we talked about that, and we talked about the barriers to that, you know, time, all the stuff you have to learn. And I was just kind of like, well, school is like the black and white, right? It's incredibly structured. It can be very pathoanatomical because you guys don't know as much yet. It has to be that way. It has to be black and white. It has to be a little bit more structured because you don't have that real life connection yet. Once you have that real life connection, it actually means something. So if school is like the black and white in structure, Clin Ed is teaching you the gray and applying the black and white to make gray. Mm-hmm. And he was like, oh, okay. And then just thinking about, you know, okay, so if Clin Ed's the gray, what is residency? I'm like, maybe residency is like the black box. But meanwhile, you're just like supported so much, like as you're adding on so many layers, right? Because in school, I think we're starting to in school talk more about barriers to care, like socioeconomics and social determinants of health and everything else. But you're not really going to know until you're in the clinic. You just won't. So being able to have a mentor to deal with those added layers, plus the layers of 5 or 6 comorbidities, because they're not going to have just one, like in your, you know, PT classes, is super, super valuable. And that's how I think people should think about it when they're going into Clin Ed. This is an opportunity to apply what I learned and get the most out of it with someone who is supposed to be my mentor.
And Kayla, like on that, do you mind if I jump in?
No, please.
Like Kayla, on that kind of continuum and piece of it, like it's funny, I've been writing a lot of curriculum and goals and like things like it for residency, and in the classroom, I'm seeing all that. And I always like Bloom's taxonomy is always just like this like Google image that I just have because it's just helpful. And I think of it kind of on that, you were talking about like the scale and but you think of like the school and like the black and white is that like first level of like, you just have to remember it. You just have to like know the facts. You just need to like know things in school. And then like ClinEd, like full-time experiences, practical experiences are helping you like, you're understanding it a little bit more. Hopefully you're understanding it in school. And then you're like applying it. And it's like clinical education is that like mid-level in Bloom's and then like residency is like, oh, well now things are like, you learned it, you applied it, you had all of these patients, but now you're like, I'm going to analyze this and like realize that there's maybe something new, and you're going to start to be like really independent and really autonomous. And you're going to start to challenge some of those, like even the clinical practice guidelines. You're going to start to look at them and say, but does this person actually fit into it? Like, who are the responders to all of these things that I learned? And like, what if they're not responding to even the high level evidence?
What now? What do I do
now? And so I think it's just like, it's almost like that layered learning, and it's like, it just keeps going from there.
I love where this conversation is going, and I've never thought of it, and I've definitely thought of the black and white concept like you discussed. I never took that leap to ClinEd being the gray, and I like that a whole lot. But then when I try to think about where I would place residency in that, I almost wonder if the gray might be residency, because that helps like control some of that variability. It gives you like the opportunity to, how many times do we have someone for 10, 12 weeks for a clinical experience, and then the day they leave, this other patient comes in that would have been like the perfect learning experience for that student. Every time. Or they don't see someone fully to a successful discharge or something of that nature. So I feel like just the length of residency helps control variability while still doing it in a very evidence-based practice way, and we're not getting just kind of cast out to I don't know, to the start of a profession, because there's so much variability across clinical experiences and just clinical environments in general. So I wonder if that clinical experience isn't like the matrix, just it's grays and whites going up and down all the time or something that makes it kind of messy. Moyo, I saw you on mute.
If I may, this is a great conversation because I'm going to throw in fellowship training, which it was just, for me personally, it wasn't until I completed fellowship training that I really changed the way I did clinical instruction. It's interesting because, you know, much like you, Maggie, you went through a residency. I think you said you went through a residency, and it teaches you how to learn, but also how to synthesize information in a different way. I think what fellowship training did for me was to make me, it was metacognition. It was thinking about thinking. So it was, you know, there's this one region of the body, what are all the things that could be involved? And then what are all it just kind of took it to the next level for me. And I immediately started to apply that to clinical instruction. But then you also have to say, hey, is this too much? Because this is supposed to be an entry level, learning environment. And again, checking my teaching was, I'm going to expose my student to this because I've gone through this training. So why not learn from a fellow the way that the fellow learned, but I will hold you responsible to the appropriate standards, which is entry level PT care. So students appreciated it, and they would have a sigh of relief knowing they weren't expected to be fellows by the end of their entry-level clinical experience, but fellowship on top of residency and all of these layers and levels, I think kind of takes us back to clinical instruction and all the different places you can really go with teaching.
Yeah, and Moyo, I think that's a valuable thing to be showing students, like opening that door the slightest bit, cracking it so they can see what's in the future. You think of kind of first generation learners in higher education. You're kind of opening that door and saying, no, there's these next steps that might be coming down the line. So perhaps they're not absorbing it day one, but they at least know it exists. I think there's value in that for sure. Kayla, I'm going to tie the conversation back to you. Talk about like resources. So we're talking a lot of theory, a lot of one-on-one with a student. When you were hungry to enter clinical education, where'd you go? What'd you look for? How'd you decide I was going to become this clinical instructor?
A couple of us have mentioned the APTA's credentialing courses. They're incredible. I recommend to everyone who's even vaguely interested in being a CI to take it if they have the opportunity. Level 1 is teaching you how to be a CI, the structure of, clinical education experience, how to give feedback, how to really look at what a student's doing and break it down. Challenging a student who is exemplary, supporting a student who may be struggling, kind of the bookends, because in the middle, I think people do pretty well, but it's the bookends where people maybe need a little bit more support. Podcasts, I really liked the health education podcasts. I took one of your courses, which was great. Even talking to my mom, like talking to someone in education. I looked back at some of my old notes from PT school on behavioral change, and I remembered Bloom's taxonomy. And I'm like, you know research in education, and it doesn't have to be education necessarily in PT. It can cross disciplines, not even just healthcare, but healthcare and education. So I talked to her about that stuff too, and also just speaking to other clinicians who had been CIs before. How much of a time commitment is this? What should I expect? How much time did you spend on the CPI? Those sorts of things that can only really be known, like the barriers or facilitators in your clinic, right? You got to ask the people who work there. Mm-hmm. So those were the main places I got my information from.
Yeah, that's helpful.
And one more, just self-reflecting on my own experiences as a student, and also just seeing, my fellow coworkers work. And even now, and I was just thinking of this recently, I had a really, really tough patient, bilateral BPPV, and I had my first BPPV conversion, and I was like, oh my God, I've never had this happen before. And so I asked one of my coworkers who has 20 years of vestibular experience, can you kind of tag team with me on this? And afterwards, she gave me some tips, and we tried some things. And, I have my NCS, but there was still a moment where I was like wide-eyed. I was like, this person knows so much. This is so cool. But they're also talking so fast, and they're so, like, they know 100% what to do. And it made me go back to like, how do my students feel when I do this to them? So just constantly self-reflecting too on like how I give instruction, and kind of putting myself in my students' shoes also, in being a lifelong learner and asking for help, and just kind of reflecting on how does it make me feel to have feedback? How does it make me feel to get constructive feedback? Was I willing to change what I was doing? You know what I mean? So I think being a self-reflective person is only going to benefit someone if they want to be a CI. It keeps you honest.
Absolutely wonderful. Others, in terms of resources or things that you've tapped into, whether it be in building curriculum or in doing kind of the one-on-one clinical education with a full-time student, that comes to mind? I'll throw out there, we're on an ACAPT call for sure. I think ELC is a magical place. It is like Disneyland for clinical educators. And I wish we could fill each of those rooms and each of those halls with more and more clinicians. And that number keeps on slowly kind of ticking up. But I think there's such great just conversation that occurs by having the two sides. We're interacting with someone like Duncan, the moments before they leave for their clinical experiences, and the moments after they step into clinical education, and the presentations and work that's done there, and having that conversation from the clinical to academic side always seems to be just, again, magical, knowing where the person's coming from and where we have to kind of carry that baton to on the clinical ed side. I love it. I don't want to get this conversation negative because it's been so positive. So I'm not going to talk about any of the broken stuff or any of the barriers, the ugly stuff. I want to kind of go around the horn. Clinical education, is it a specialty of practice? Like, how could you see that happening? Why is it? I'd love to hear just the panel's expansion of that. And Duncan, I'm going to include you in that conversation because you haven't touched it, fully in your full-time experience yet. So I'd love to hear your take on it as well. And if you're brave enough, maybe start us off.
Yeah, so I actually thought about this question for days because I was kind of trying to think of like, I don't know, but from an objective viewpoint, I think it certainly is, because I work at a clinic right now and you see like PTs and they're great at their job, but I think it's that added piece of not only treating a patient, but like getting a student to come from that black and white to that gray area and have them being confident in it to then go out on their own. And I think that's pretty commendable. Like I don't know if I could ever do it. It probably takes a ton of patience, a ton of, research, like everyone's mentioned. So I would certainly say it is a specialty from just an outsider's viewpoint. And I kind of took this question and kind of spun it a little bit, so it made more sense for me. And I kind of took it as clinical experiences for me are now specialty education, right? So I have my coursework and everything, but now I am transitioning to experiential learning, which is kind of unique in nature because it's learning on the fly. It's constantly reflecting, it's applying everything I've learned and actually doing something with it, which is super exciting. But it's that like becoming an actual professional with everything I've learned the past 5 years. So I think it's definitely a specialty to be a clinical instructor, and it's that specialty education piece that I've been really, really looking forward to getting a chance to kind of dive into. So
wonderful, Duncan. Thank you so much for that insight. That is absolutely wonderful. Anyone else want to kind of take a stab or where their mind was at with that question?
I love that answer, Duncan. That's a really nice way to look at it. I might take that and take it to school and to class on Monday. But I don't, clinical education right now is not a specialty or subspecialty, but I think it definitely could be. There's so many moving parts to clinical education that, if we broke it down, it could be experts in the placement process. It could be experts who are field trainers for clinical instructors. The credentialing course is great, but then you go into the field and you might forget some stuff. But the resources, the handbook, like they're all there, but there's something to be said about a human being who's sort of there with you, almost like when you were a student, but training the CI, we could go to a group of experts who just do site development, and that's all they do for all of us. We could look at it as, we could have specialists and subject matter experts who focus on mentorship for clinical instructors, for students in the clinic. It's like subspecialties within this big umbrella of clinical education. If all were perfect in some ideal world. Because when I say that, because there's so many stakeholders in clinical education that not touching the broken question in terms of what systems are broken, but I think sometimes we operate in silos and we're not including all the stakeholders who are involved or maximizing that potential to engage. And so, what systems do we need to put in place so that all the stakeholders are thriving, and clinical education is this magical place like ELC, so I think there are probably subspecialties within clinical education. I know that the NCCE is kind of broaching this with some task force, and there's a lot of work that the academy is doing. And so I think there's attention to it, which is essentially how systems change and grow and evolve. So I'm just looking forward to the work and somehow remaining involved in this work. Because ClinEd we won't exist as a profession without clinical education. So we should figure it out.
And just great perspective from them, Moyo. I think that's a missing component of this kind of discussion this evening. I think the stakeholders are not simply what's on the common terminology list, which is CI, DC, and SCC, right? Because you described some of those roles, and in some environments in a rural community, perhaps that SCC is doing all of those things you just described on the clinical side. On some big medical systems, there's administrators, there's multiple levels before it gets down to someone that actually has a PT after their name. I think you're absolutely right that like a specialty of clinical education would have to be so broad to apply to all of those categories that there probably is some subspecialty captured within there. So great perspective.
I'll jump in. So I think when I was thinking about this question, I was like, well, how much of our education in PT school is clinical education? I don't, do you know the answer? Like the number, Moyo probably knows. How many hours do you have to spend in a clinic during DPT program?
Well, it ends up being about 30% of the academic class.
Yeah, so think of all the training that your professors go through to how to be able to teach in a classroom. And then it's 30% of your experience is just left up to like whoever wants to sign up to do it. Like, not that all, like there's some, like Kayla's an awesome CI, like the CIs on our CI team are amazing and they put in like so much time and effort, and it's this like cultivated experience that is just like an amazing CI program. But then there's also like clinical education that's like so different, and I think the majority, like the variety in that, it like shows that like, yes, it needs to be a specialty. Like, it's just like, why are we just okay with 30% of education being like, there's so many like standards and there's so many things that we pay attention to in the classroom, and then it's like 30%, that's huge. Like if you got 30% wrong, Duncan, in your program, like you don't pass, like you don't become a PT. So I just think there's like, at face value, I think that like that in itself is just like a very stark like fact that needs to be addressed. But then at the same time, like you think of like, what is resident? Like I just wrote a lot about like, what is residency? And it's like, it's post-professional training and it's in a specialized area. That's like the phrase that comes up when you're trying to figure out like what actually is a residency. And like specialty, like it is a specialty. It's a special skill set to foster student learning in the clinic. And like Kayla can probably jump in and talk about like what it really takes to like do it. But when I think about how I was preparing for this role as a residency director, I was breaking it up into like, okay, I have to be able to do this. I have to be able to do it. Like I have patient care, I have mentoring, I have didactic work, I have the support, like, but like being essentially the CI and the mentor, like to the resident at a higher level was a skill set that like, I had to figure out how am I going to do this? And like, I'm still working on and will always be working on how to get better with it and work with our ClinEd team who is, you know, who are fostering student learning. Like I'm going to foster resident learning. And so it is a specialized skill set. And so if it's important and it matters and it's a specialty area, then like, I think it's a pretty straight lead.
I love it. And Maggie, if you had made those statements years ago, it would have been taboo and we would have been like, don't say that, don't say that. Because that was kind of like what was hidden in the closet, I think, which was it is such a vital part of academic physical therapy and what it takes to train a student to become a physical therapist. So I think discussions like this and the ongoing kind of body that Moyo was discussing is the snowball that is changing that that kind of forgotten child in the corner that is such a large component of the education process.
When I was looking into this question, I literally Googled specialty definition because I was like, yeah, of course. Like initially I had my initial answer, but I was like, let's think about it a little bit more. So a pursued area of study or skill to which someone has devoted much time and effort in which they are expert. I'm like, yes, I did all of that to be a CI. Like you devote a lot of time and it is a skill set. My only hesitation when I think of the word specialty and when I think of what my peers might think of as specialty is people hear the word specialty and they go, oh, that's not me. Like, that's not me. Like, that's not something I want to be able to do. And my original idea for my Centennial Scholar Project was educating people in like 2-to-1 models or collaborative models or something that was a little bit more flexible that also got more students into the clinics. Because I think we have to acknowledge that there aren't enough clinical affiliation spots. And a big part of that is some people aren't, or, you know, there aren't enough people who are willing to be CIs, or there aren't enough CIs who are willing to take more than one student at a time or one student during the year. So absolutely, I think we can include it like as a definition, as a specialty, in that you need a specific skill set. And I think it's important to raise the bar, right? Because it is a third of our education. So CIs who are willing and want to like undergo that training, I think we should all go for it, but maybe not, you know, making it a specific certification and scaring more people away who might be interested in like dipping their toe in. Like maybe if they dip their toe in, they'll jump in fully, right? I worry about labeling it a certain way. But I think that's partially me playing devil's advocate in the conversation.
And Kayla, when I was thinking about that too, I also was thinking like, when you think about the time it takes, the like financial, emotional time that like it takes to do a residency, like if you think about then like, who are the CIs, what positions are they taking, what's their like take home, other than like being better, which yes, we all want to be better, but like, is there the reality of like that pathway, like where would it lead? I think like some of us are in positions that it leads to, but like for the person who wants to stay in the clinic and like be the CI, like if you're asking someone to like go through a residency program, if that's time and money and we're asking people to like go through that, are they then gonna like see that on the back end also? Like, I think that's just it's not like the pretty part, but I think it's a reality of it.
Yeah.
Yeah.
I was just going to chime in about even the challenge of getting CIs to take the credentialing course, like, and that's not the same gravity. I mean, and it's no disservice to the course itself, but you know, I remember lots of conversations. We had a lot of initiatives to encourage clinical instructors to take the course, but it's not required. So some people have 30 years of experience. I'm not taking the course. My experience will teach my student. So I think we'll be hard pressed to find some buy-in, interesting buy-in on even taking it further. Like I think there's a minority of individuals, maybe this could be wrong, who, you know, can really put that hat on and see where ClinEd is and where it's going. And can they see the value proposed in directing it toward a specialty? But I think if we go back to even some of the fundamentals that already exist, how do we engage our stakeholders once again, you know, get clinicians to ELC, encourage people to take the course, you know, it is helpful. Funny enough, I had a conversation with a coworker today who didn't think it was helpful, but that was because she had experience. She took the course after years of experience and didn't think it was helpful for her. I took it, you know, within my first 2 years of being a PT and thought it was amazing. So that's something else to consider. What are we going to give our long-term PTs, you know, for lack of a better word, to encourage this, you know, continued professional development? And what are we going to give our new grads? Those have to be two different things. Those are two different types of stakeholders. So I think there are just so many layers and so many parts, and you know, the work is being done. There's, you know, task forces and reports. And so I think we're on the right path, but there's a lot that goes into potentially taking ClinEd into a specialty, I think.
Yeah, and Moyo, I'm going to steal some of your words from the beginning. You described yourself as like clinical educator as being part of your identity, right? Or one of your identities. And for some reason, and maybe I'm wrong, but for some reason, it feels like the new graduate that's going to go into ortho, or they're going to be a sports physical therapist, I think sees it just, if we use black and white again, as I'm a physical therapist and I'm a sports physical therapist. I think there's no reason why that third identity can't be, and I'm a clinical educator. And I would love to see more and more of those people that are just passionate about the depth of learning to also have this side that is viewing themselves as a clinical educator. So it's going to be a little off the cuff. If we have to edit this portion, who cares? But talk candidly. Maybe think about what would be some of that advice you'd want to provide to the entire graduating 2022 class of physical therapists into the world for why clinical education is important, why people should be thinking about it, why people should pursue parts of it within their career. Around the horn, whoever wants to jump in.
I think a couple things. Just because you're a new professional doesn't mean that you don't have something to give. As a clinical instructor, I support, you know, working for at least a year before you jump in to be a CI. But I even have people who've been practicing like 3-5 years. They're just like, oh no, like the students are gonna know whatever they say. And I'm just like, just go for it. Just go for it. And for clinicians who have a lot of experience, I love a line of Mo's that goes, I selfishly take students because they teach me things. Mm-hmm. And I think just, you know, remaining humble of that, because, you know, I've been out of school 4 years now, and these students are coming out with things that I didn't know about in school. So instead of acting defensively, it's like, oh, why don't you tell me about that? Or, okay, tell me how you would apply it to this patient. If that doesn't work, what are you going to do instead? If it does work, how are you going to progress them? So just dive in. I think to Mo's point also, I feel like there's kind of a sense of duty that you should do it. Think back to your CIs who you thought were awesome, and think back to your CIs who maybe weren't as awesome. Because I think it would be totally amazing if everyone had all their CIs be perfect educators and totally great. I have not met someone who's had that experience yet. But I think if we reflected on those experiences, both good and not so good, and people use that to motivate themselves to be a clinical instructor, I think that would make ripples that would become waves, like people who would change the status quo. Because I think with how things are going in PT and clinical education in this country, if you just go through an experience, but then you don't learn from it and then do something, nothing's going to change.
And to your beginning part, Kayla, I think you expressed like the person on the sidelines being fearful that the student's going to know more than them, or that they're imposters to being a clinical educator. I think I'd add on to that too. People get caught up in, well, the caseload that I have, or the environment that I'm in, or whatever the situation is. And I think, or
they're a first-time student. Yeah.
Those are like those exactly. Those are the best. There's so much learning that can occur in that. A student going off on home health affiliations, or someone that has a unique role and position. They're working 3 12-hour days, whatever it might be. All of that variability, I think, just helps enhance the variability that exists within physical therapy. So.
Yeah, if not now, when?
Mm-hmm. Yep. Yeah.
And to tag on to that a little bit too, I think when you think, I think about like in school, we think about the person who like you're hearing someone up here saying like, oh, ClinEd is great, you should like go into ClinEd, and you're a student, and like Duncan, maybe you can talk on this a little bit, but you're like, how am I going to teach someone out? Like, I'm still learning, I'm still trying to figure it out. I think like even I, who was in school knowing that someday I wanted to like do some teaching, still thought like, I waited a year to do my residency because I was like, I have to learn before I go learn more, and I have to learn, I have to finish my residency. Like, part of the reason I did a residency was because I was like, well, if I want to teach, I need to know a lot of information in order to be able to teach. Like, that's what I thought at the time, because I was like, I don't know, that's what I thought. And now I'm realizing, like, if you think about some of those learning experiences that you have, even now, you think about like the person who was teaching you when they didn't know something, and then you had to watch them go through their process of like, when I don't know this, what do I do? And that's an experience, and that's like a powerful experience that you can have. And so I don't think of it as like there's this finish line that you can get to say, now I know enough information to be a clinical educator. And you're never going to get there. We're PTs, like we're always learning. We're never going to feel like we know everything. There's always going to be a patient that walks in the door who challenges us, and there's always more to learn. And I think that's like an awesome part about our field. That's like one of the reasons why I love physical therapy. But in that sense, like if you're waiting for that moment where all of a sudden you feel like, well, now I'm an expert enough where now I can share my knowledge. Like, there's always knowledge that we can share, and working through experiences with students, with residents, with whoever it is. I think like allowing people to see that. You mentioned the variability of the experiences, but also just the reality of what is it like to be a PT? How can you be a better PT? The reality is that there's going to be times where people come in and you don't know everything you need to know. How do I go find that information? That's part of the learning process too.
Yes, Maggie. Yes. And you can have the NCS letters after your name, but the first day that you have that NCS, you're not the same physical therapist that you are on the 1000th day. And I would say the same thing of being a clinical instructor. So anytime you jump on that carousel, you're going to grow in that process and improve your own skill set as you go.
Yeah. And like, I went to get an NCS because I thought it was going to make me a better teacher, and like it had nothing to do with teaching. And I was like, oh shoot, I got a lot to learn still. Like it's, yeah.
I love it. I love it.
I'm right behind you, Maggie. I did my OCS maybe just 2 years ago for the same reason. Fellowship taught me so much about teaching, and I was like, there's this one other thing in orthopedics that I'm missing. Oh, I'm going to go sit for the OCS. And it was great because it was you know, fellowship training is a little bit different, you know, than sitting for the OCS exam. And so putting those things together for me was like mind blowing. And I had students at the time, so they got to see the struggle as I studied and tried to apply both things. And it was interesting. The students probably were stronger and helped me prepare for the OCS because they were getting a lot of that information in school, you know, kind of more the standardized orthopedic things. But I really appreciate your perspective because I did the same. I went back and I got my OCS. But back to the topic at hand, I think if I can put my DCE hat back on, introducing clinical education in the classroom is going to be important. I think a lot of programs do have clinical education seminars for that. I know we had them at Duke, and there were really key things that stuck out to me when I was in school, strictly about PT education. So for me, it was sort of like, that just lit me up. Like physical therapy itself, the biomechanics, the anatomy, all of that is wonderful. But I really remembered expert practice in PT, professionalism in PT, and clinical education. So I think the calling was always kind of there, thanks to the instructors who delivered the material. And so I think I sort of have this same sense of responsibility to deliver this content in such a way that, sure, it won't hit everyone like it hit me, but I need to introduce this as part of the seminar. I completely understand the students may not grasp it. And just sort of thinking how to infuse it into the curriculum, it's gonna be about timing. So making sure they have context. But again, to Maggie's point, these are the sharpening teaching skills struggles that as a new DC, I'm gonna have to face, but clinical education is just part of the clinical education seminar. So teaching students how to teach, whether it's role play, you're the CI, this is your classmate, teach them how to do this exam or some other form of meaningful learning experience. So I'm looking forward to it. I don't have the answers and the perfect strategies yet, but someone does. There are resources out there and I'm going to use them.
Oh, I absolutely love it. Great way to kind of wrap us up, Moyo. And I think we're gonna have to you back in like, I don't know, 3 years, 5 years, when you've got like the DC thing just like figured out and you can tell the world.
I'll be back.
Again, thank you to the panelists. I think this is wonderful. There's a common thread of just clinical education throughout everyone's careers here. And I think that's a vital story that, again, needs to be kind of told. For those that have like kind of listened along the way as we go, Kayla had brought it up. We're mentoring individuals from the student to the classroom through their careers. I don't know, take your blinders off and see that there's so many different avenues that people can be a touch point along the clinical education kind of continuum. We have traditional CI positions here. We have DCEs, we have clinical residency directors. There's lots of different spots for people to thrive in the clinical education community. And I think the more that people are just aware that, hey, this is something I can go do, or this is a door that's slightly opened a little bit to view into, I think is a helpful process. So thank you very much to the panelists, and do reach out if you guys have any questions. I really appreciate it.